Welcome folks, welcome colleagues, welcome to MuniMeterHealth, your source of learning about cardiology and human heart awareness, and of course about the human heart. Welcome again, this is Dr. Jaitly from New York on your source, MuniMeterHealth. This brief video will be discussing epidemiology of heart failure. Well, we know heart failure is an ever-rising epidemic, and the prevalence is in the US alone. If you were to look at, the numbers are the following. We are about almost 6.5 million people actually at any point of time within a year that has a pool of 6.5 million people within the US. So globally we don't even know. The World Health Organization, WHO, keeps the track of what's going on in the epidemic, but just in US alone it's 6.5 million. It used to be 5 million only about 4 years ago. At one point of time, that was the prevalence. Now the incidence, that means the new cases that are being reported, it's almost about 9.6 raised to the power of 5, if you will, or in other words, almost a million new cases are being reported. However, there is a mortality of almost 500,000 people. They are dying. So in other words, we are losing approximately half the cases that are arriving new into this pool. So we are losing almost like 0.5 million people, if you will, per year, despite all the medical therapy and the devices and that's coming along. So we have made some progress, but not to the extent where we want it to be. And the problem is the prevalence is increasing, because now I always say we are not dying of ailing hearts, we're dying of failing hearts. So just remember that, because we are living longer primarily because the myocardial infarctions are being addressed, the CAD, the ischemic heart disease, the ischemic cardiomyopathies, a lot of myocarditis are being now addressed. So what's happening is people are dying of heart failure now, and of course they're living longer, but that's the ever increasing epidemic. What are the costs in the US? Well, we are now almost approaching $150 billion. Folks, this isn't billions. We're almost approaching $150 billion directly or indirectly related to the care of patients of heart failure. Just remember that. However, these numbers are, grossly represented, because you're looking at not only the hospitalization rates, you're looking at the diagnostic rates, you're looking at the therapy, which is getting more and more expensive. Some of the tests are getting more expensive, and of course the hospitalization rates are huge. And then you're looking at the other expenses involved as an outpatient, or even during the times when patients are undergoing certain device therapies. So this is just alone in US we are spending about $150 billion almost. That is as of 2016. Now, functional status is very important, because the greater the severity, the lesser is the functional status of that individual. So you may classify heart failure class 1, New York Heart Association say 1, the chances are the functional status will still be maintained to a level that the patient can perform, go out, drive a car, etc., go to the grocery store, bring back few things, etc. So that is a functional status. But if class 3 and class 4, those patients obviously have a significant compromise in the function, the severity is higher, obviously, that's almost a no-brainer. But the fact is the severity will translate into the mortality. Just remember that. So that's how it works. So and the more the number of hospitalizations that occur. Now here we come to the hospitalizations, for instance. Here we find that it is the number one cause of all US hospitalizations right now. So if you look at the DRGs, you look at the ICD codes, you find that the number one cause for hospitalization of any individual right now, the chances are this person has heart failure. So it is a very important entity. It should not be forgotten, and that's why it's taking the brunt of the cost here to an escalation of almost $150 billion directly or indirectly. Optimal therapy, only about 40 to 50%. So I call it 50% are receiving therapy which is optimal, which may be either the correct dose, or we are looking at the correct medications, so dose or meds, either of those two have to be optimal, and only 50% of these patients in the United States are really achieving it. We do not know whether the Lasix or the diuretics have been optimized. We do not know if the beta blockers have been optimized. We do not know whether the ARNI has been initiated. We do not know whether the aldosterone has been initiated in the right context. So the whole idea is that this optimal therapy, where 50% of these patients only are getting optimized with therapy, that leaves another 50% waiting to be addressed. So those 50% of the patients should be followed more closely, both by research, both by clinicians as an outpatient and also as an inpatient. So this is the pool which can actually impact on the mortality. Therefore, you can reduce the mortality, which may improve the prevalence rate because more patients will be surviving longer. So the prevalence pool may actually sort of increase, but the very fact that the mortality can be reduced by optimization of the therapy. Okay, so these are just a few nutshells on epidemiology. Again, heart failure defined as failure of the heart function to meet the necessary demands of the body as a result of either a systolic dysfunction or diastolic dysfunction or a mixed function. Again, this is beyond the scope of this short video, so we do short videos primarily to encourage medical education and of course patient education in order to improve the clinical outcomes. That's a major goal at MuniMeterHealth, so please stay tuned for more and follow us on heart failure playlists, if you will. And if you click the button on playlist of heart failure, you'll get the entire heart failure spiel one after another into, so this way you can learn better, especially people